Hi, good afternoon. Welcome to CPAN, the last one for 2024. Today, I'm going to introduce two speakers. Dr. Shotwell, he's a board-certified child and adolescent psychiatrist. He is currently an associate professor of child and adolescent psychiatry in the Department of Psychiatry and Behavioral Sciences at the University of Texas Medical Branch. His primary role at UTMB is serving as medical director for the UTMB Texas Child Health Access through telemedicine program through the Texas Child Mental Health Care Consortium. Our next speaker is Benita Leilani. She is a third-year medical student at the University of Texas Medical Branch with a strong interest in pursuing a career in child and adolescent psychiatry. She is actively involved in research and leadership roles within the fields, including serving as chair of the American Academy of Child and Adolescent Psychiatry mentorship program, and is presenting on critical mental health topics such as vaping-related nicotine dependence in youth. Benita's dedication to mental health advocacy and her experience in addressing complex issues in youth populations make her a valuable voice in today's discussion on suicide assessment and the safety planning for primary care providers. So please welcome Dr. Shotwell and Benita Leilani.
All right, thank you so much for those introductions. And I appreciate everyone taking time out of their lunch today to join us for this refresher course. So give me just a moment and I will try to get to where I can share my screen. Can you all see the presentation okay?
We can, thank you.
Thank you. I can never tell. In full disclosure, my computer does not like Microsoft Teams. So if anything is not working, please just let me know so that I don't continue talking to myself.
Okay, thank you. And at the conclusion, there should be, if they have questions, they can put them in the chat box so you can read those as well.
Oh, yes, ma'am.
Okay,
That would
thank
be
you.
great. All right, so our topic today is suicide assessment and safety planning in pediatric primary care. This is a presentation that I gave about a year ago. So for those of you that may be joining for the second time, it's always good to get a refresher in this particular topic because it's so important to what you all do in primary care. So joining me today is Benita Leilani. She's a medical student. I'm also an associate professor that works at UTMB. Neither of us have any financial disclosures. So in terms of our agenda for today, we're going to start by reviewing the most recent suicide data and statistics published by the CDC. Benita will then discuss some of the risk and protective factors for suicide. She'll also discuss potential warning signs that an individual might be considering suicide. We will then take a look at some of the youth suicide screening recommendations from various national organizations, and we will explore some of the evidence-based suicide screening instruments that are available to clinicians. In particular, I want all the clinicians on the call to leave today feeling comfortable using the Columbia-Suicide Severity Rating Scale to assess suicide risk in youth. I also want everyone to leave today's talk feeling comfortable with their ability to develop a suicide safety plan for you. So why should we talk about suicide? Well, it's one of the leading causes of death for individuals in the United States. On average, close to 50,000 people die every year by suicide, and millions more contemplate suicide, and as many as 1.6 million individuals attempt suicide every year. So if you think about it, just in the amount of time we're going to spend together discussing suicide today, as many as 5 individuals may take their life by suicide. So let's take a closer look at some of the suicide statistics shared by the CDC. This graph is part of the most recent data released which usually tends to run a few years behind. So the latest data we have now is 2022. And the general pattern for suicide rates over the last 2 decades has really been a steady increase. You can see a slight dip from 2018 to 2020, but then it quickly rebounded back to the 2018 rate, and it's kind of been holding steady since then. And this is despite increased awareness about suicide nationally and widespread efforts to reverse this trend. So suicide is common across the lifespan. No age group is immune from the risk. This graph shows us the suicide rates per 100,000 individuals in the US population. And the age range with the high suicide rate are really those that are 85 plus. The age range with the lowest rate is really down at the bottom, age 10 to 14. I will point out that individuals in this 15 to 24 age range, they have almost as high of a suicide rate as most of the adult groups. So the later into adolescence you get, the higher the risk of suicide. So even though the risk of suicide is lower in individuals less than age 24 versus older adults, it's really important to realize that suicide is the second leading cause of death in this group. These are people that would otherwise be unlikely to die if not by suicide. This group has also seen one of the largest increase in suicide rates over the past 2 decades. As you can see, 52% increase for that particular age group. Further highlighting that crisis amongst youth was a 2021 nationwide mental health survey of high school students, where as many as 9% of high school students reported having a suicide attempt in the past 12 months. This risk is even higher for individuals that are non-heterosexual, where as many as 1 in 4 had attempted suicide in the prior 12 months. So this is an area of increasing concern. So there is a graphic on the CDC website that shows the leading causes of death in the US for individuals aged 1 through 44, and it really spans from the 1980s into the 2000s. So you can click the graph and watch it change by year. I don't want to necessarily switch over to the graph right now because I'm afraid I'll have difficulty sharing it and getting back to this screen. But I do think if you have time, it's great to go and take a look at that. It's amazing to see how the leading causes of death have changed over time, and you can really appreciate the fact that suicide deaths creep up over time until they're the second leading cause of death. Something else I like to point out about that graphic is watching it during the time of COVID-19 pandemic. I was personally surprised to see that deaths by suicide exceeded deaths by COVID, even in the peak of the pandemic. And I think for me, that really helped put this crisis into perspective. When we look at race and ethnicity, we see that American Indians and Alaska Natives have the highest age-adjusted suicide rates per 100,000 individuals, followed by non-Hispanic whites, Native Hawaiian and Pacific Islanders, and those that identify as multiracial, non-Hispanic Blacks, or Hispanic. Non-Hispanic Asians have the lowest overall suicide rates, but it's important to note no race or ethnic group is immune from the risk of suicide. Being male also places you at a higher risk of death by suicide. Males are approximately 50% of our US population, but unfortunately they account for nearly 80% of all suicides. Something else to keep in mind is location. Suicide rates vary based on location. Suicide rates tend to increase as an area becomes more rural. This is important to note as many of the individuals on the call today are primary care providers providing care for individuals living in rural or under-resourced areas and are therefore at higher risk. So up until this point, we primarily discussed risk factors for suicide that a person has very little control over: age, ethnicity, race, gender. We might even lump location for pediatric patients into that category, given children don't generally have a say in where they live. So now we're going to transition over and talk about risk factors that can be modified. One of the biggest risk factors for suicide is access to lethal means, such as a firearm. When we take a look at how people die by suicide, firearms account for more than half of all the deaths by suicide, followed by suffocation, poisoning, and other means. I am now going to pass over the presentation to Benita, who's going to discuss some of the various risk and protective factors you might want to consider when you're evaluating someone's individual risk for suicide.
Thank you, Dr. Shotwell. I hope everyone's doing really well today. These are just very important things to keep in mind. I know many of you probably have it in the back of your mind, but it doesn't hurt to go over. So when we talk about risk factors for suicide, it's important to recognize that these factors are often deeply personal, and they often overlap. They don't necessarily cause suicide on their own, but they increase vulnerability. So to briefly go over a few of these, previous suicide attempts is the strongest predictor of future suicide attempts. The more attempts that someone has made, the higher the risk there will be in the future. For mental health disorders, conditions like depression, bipolar disorder, anything like that can cause distortions in thoughts, perceptions, and make challenges often feel impossible to overcome. Someone with severe depression might think that a simple task like washing the dishes is truly out of reach. Serious illnesses or chronic pain, when we think of things like fibromyalgia or cancer, these can severely impact quality of life. The constant physical pain that someone feels can lead to emotional exhaustion, potentially leading to suicide. Criminal or legal problems. So if you're facing something that is serious within the legal system or consequences that are through the legal system, it can create overwhelming stress and even social stigma behind that, which can kind of lead to a sense of hopelessness. We have job or financial struggles. These can affect self-esteem, security, and also just the ability to meet basic needs. Then we have impulsivity and aggression. So untreated conditions like ADHD can lead to dangerous decisions. Adverse childhood experiences, so any trauma, abuse, neglect in your early life can lead to potential issues in your future relationships. Hopelessness, the sense that things will not get better in the future is kind of a common thread that's connecting these factors. So it's crucial to remember that these factors interact. Someone with a chronic illness might also face financial difficulties, or someone with a history of depression might have childhood adverse effects. So just knowing that these things interact are just a very important part of understanding the risk factors. Talking a little bit about relationships, we know that relationships are central to our emotional health. Positive connections can be a source of strength, whereas harmful experiences can really increase the risk of suicide or having bad outcomes. So bullying, this can take many forms. We can have verbal, physical, or even cyberbullying, and the effects can truly be devastating. For children, teens, even adults, you have to understand that bullying might make it seem like they are a target in their daily lives. For family and loved ones' history of suicide, when a family member or a loved one does die by suicide, it can truly be a traumatic experiences that follows someone throughout their life. And it might make someone have struggle coping with their own issues, thinking, if they couldn't do it, how can I deal with this? And so it makes suicide more of an option to their issues. Losing a significant relationship, this could be breakups, divorce, or even death, can leave a person feeling unanchored. High conflict or violent relationships, being in a relationship filled with constant arguments, emotional abuse, and even physical abuse can erode someone's self-esteem and leave them with a sense of hopelessness. And then again, social isolation. We all need this feeling of connectedness, belonging. When someone feels disconnected from their families, friends, even their community, it can kind of just amplify this feeling of I am alone in this world. Take physical distance for one. COVID has really increased the amount of suicide that happened because physical distance increased the sense of loneliness that people felt. Talking a little bit about community risk factors, communities can truly shape our own well-being and then also increase or decrease the risks of suicide. When you have lack of access to your healthcare in your community, it makes it harder to get access to the healthcare. So imagine knowing that you need help but there's no clinics nearby, there's no insurance that you have, there's a lack of transportation. So when someone has mental and physical health needs and they're unable to get them, that can lead to conditions going undiagnosed and other issues which make people feel trapped. There's also suicide clusters in communities. So if one suicide happens and it really leads to heartbreak within the community, it can lead to others. And so that's why a lot of times when there is a suicide in the community, sometimes it's followed by a cluster of multiple suicides. For immigrants and refugees, there's stress of articulation. So immigrants have trouble maintaining their identity, and that can honestly be very stressful. There's language barriers, there's the idea that you're different, there's racial comments, and this leads to this feeling of isolation, and that can become overwhelming. You have community violence. So if you are living in an environment where violence is often common, whether it be gang violence, shootings, even domestic violence, it creates a constant sense of danger around you. And that can also lead to loss of hope, increased stress. There's also historical trauma. Some communities carry the weight of collective trauma that's just passed down. So when we think about this, we're thinking of colonization, slavery, forced relocation, and just other injustices that are systematic within the community. And the shared pain can affect your mental health. And then again, discrimination. So gender identity, sexual orientation, religion, and other aspects of your identity can really be harmful when it's taken in the wrong way. Discrimination just creates these barriers to opportunity. Okay, and then the last one is just societal factors. Yeah, sorry. So sometimes when mental health issues are stigmatized, people may avoid seeking help. So if you're an individual in a rural area, there might be this fear that certain cultural groups may judge you to seek mental health. Even physicians who are trained to help others often don't want to get treatment because of the fear of judgment from other physicians. Then you have easy access to lethal means. When someone has access to firearms, as we discussed before, it can increase the risk of suicide. And then finally, unsafe media portrayals, movies, TV shows, social media. It's just ramped up in recent years, and oftentimes they sensationalize suicide and the idea of suicide. And it's often poorly handled, and this might just encourage vulnerable populations that they can imitate these actions and they'll be sensationalized in their own life. Now talking a little bit about protective factors, though there are individual factors that are protective. So for one, effective coping and problem solving skills. When someone has healthy ways to manage their skills and solve their problems, they're better equipped to handle any setbacks that they overcome. So practicing mindfulness, talking through things with a trusted friend, or even finding creative outlets like journaling can make a truly big difference. Then we have reasons for living. Having a reason to keep going, whether it be your family, your friends, your pets, your professional goals, can really be a powerful protective factor. For a parent, say, knowing that their child depends on them can be a lifeline. For other people, it might just be the joy of having a pet, or they have a dream that they want to achieve in their life. Truly, no reason is too small or too trivial to have this as your reason for living, which is why when you're asking someone for their reasons of living, it's really important to keep it open-ended. Everybody's is different. And then finally, just having a strong sense of cultural identity. This can be very important, whether it participates in cultural events, whether one speaks their native language around, and then also just honoring traditions. Then we have healthy relationships that can be a protective factor. So supportive relationships, such as having support from your partners, your friends, your family, this can honestly make all the difference. Having a supportive partner that checks in regularly, or friends who offer a safe space to vent. If you have someone who can just show you unconditional love and make you feel valued. Then there's also this feeling of having connectedness to others. Feeling connected doesn't always mean having a huge social circle. It means that you're having meaningful connections with the people that you surround yourself with. So that could be a supportive workplace, a group of friends, a faith community, or even just having a strong therapeutic relationship to a provider. These connections can truly provide a buffer to issues that might come. And then we have protective factors for community. feeling connected through your school, community, or other social institutions. When you feel like you belong within these areas, you're more likely to have this sense of purpose and support. And then if you have consistent, high quality physical and behavioral health care, access to healthcare, both physical and mental, is essential. Whether people can easily reach their mental health services, counselors, therapists, support groups, they're more likely to get the help they need. And then finally, societal factors. At a societal level, we can have reduced access to lethal means, where if it's harder for individuals to find access, then it's going to reduce the chances of having suicide. For example, safe storage of firearms. Then you have cultural, religious, and moral objectives. So if there's beliefs that are rooted in culture or personal morality, that can also serve as a strong protective factor for you. And then finally, some warning signs. There are a lot on this page and then also the next slide. So I'll just go through a few of the key ones that I've noticed. Talking about being a burden. If someone is talking to you or talking to someone about how everybody would be better off without me, it does reflect this sense of hopelessness, and it's a key warning sign to look out for. Social withdrawal. If they're pulling away from their friends, their family, or even activities that they used to love, it can indicate that they're struggling internally. For example, if someone used to be extremely outgoing and then they just don't go out anymore, it can indicate that you need to check up on them. Expressing hopelessness, if someone says, "What's the point? Nothing will ever get better," those are significant red flags. Increased substance abuse, so turning to alcohol or drugs to cope, can actually lower your inhibitions and then also increase impulsivity and risk. So that's something to look for. And then finally, talking or posting about wanting to die, straight up saying, "I just want it all to end," or similar posts are just very serious cries for help. And these are just a few. If we go to the next slide, there's a few more. But the key is just to notice change and then reach out with compassion, and you can make a huge difference in someone's life through these. Now we'll turn it back to Dr. Shotwell.
Sorry about that. I had to temporarily stop sharing. It wouldn't let me turn my camera back on. Can you let me know if we're back seeing the slide again? All right.
Yes, we
you.
can see the
Sorry.
slides.
Sorry about that. I told you my computer just doesn't like Teams. All right, so up until this point, we've spent some time reviewing the statistics on suicide. Benita shared some information about the risk and protective factors for suicide, as well as talking about some of the warning signs for suicide. Now let's switch gears a little bit and talk about ways to prevent suicide. So the first step in preventing suicide is really to identify those who are most at risk. So who should we screen? Turns out even the experts in the field struggle to answer that question. So we're going to look at the recommendations from a few national organizations. First, the United States Preventative Services Task Force. They really aren't sure if we should screen for suicide. They cite insufficient evidence for us to screen for suicide in children and adolescents, and instead they really recommend screening for depression in individuals 12 to 18. So insufficient data for suicide risk screening, but they do recommend screening for depression. What about the American Academy of Pediatrics? What do they say? Well, they recommend universal screening for suicide for youth who are aged 12 and above. For those that are aged 8 to 11, they recommend screening when clinically indicated. For example, an individual with depression or a history of self-harming behaviors. And for individuals under age 8, screening is not routinely indicated. What about the Joint Commission? Well, they recommend screening all individuals 12 and up, so similar to the American Academy of Pediatrics. And they really want to target individuals who are being evaluated or treated for a behavioral health concern. And they recommend using a validated screening tool, a suicide risk assessment tool. The type of screening tool that they recommend, it really depends on the setting where the health services are being provided. So they don't make specific recommendations about which risk scale needs to be used. But take a look at the bottom statement. Healthcare organizations should take action to ensure the clinical staff who conduct suicide screenings are trained and competent to do so. So not only do they recommend that we want to screen individuals 12 and above, they also want to make sure if we're screening them, the people who are doing the screening are competent to do so. So 2 of the 3 organizations that we looked at recommended screening individuals 12 and up for suicide risk. So once we've kind of made a decision that that's the population we're going to target, how do we go about screening individuals for suicide risk? I want to first point out there's no gold standard screening tool for assessing suicide risk in youth. Which screening tool you use, it really depends on the clinical setting where you're working and your competency in administering the screening. So today we're just going to go through a couple of examples of different screening tools that you might use in an outpatient clinical setting. So most of us are probably familiar with this first one, the PHQ-9. This is a commonly used screening instrument for depression in outpatient pediatric clinics. If you point your attention to the final question on the PHQ-9, this question is really asking about suicide. It says, in the past 2 weeks, have you had thoughts that you would be better off dead or hurting yourself in some way? Asking patients to rate that on a scale of 0 to 3. Any non-zero answer in that category should really prompt you to spend a little bit more time talking about suicide risk. I will point out that the PHQ-9A, the adolescent version that's modified for teens, it also has a few additional questions about suicide. One of those is, has there been a time in the past month where you had serious thoughts about ending your life? And then the second one is, have you ever in your whole life tried to kill yourself or made a suicide attempt? So for a lot of us that are using the PHQ-9A, we also have a few additional suicide screening questions on there as well. Another one is the ASK screening tool, or ASK suicide screening questions. I've never personally used this screening tool myself, but I have seen it used several times, particularly in hospital settings. The first 4 questions are really your screening questions. And if you get through all of those questions and the answer is no to all of them, then you've essentially completed your suicide screening. If any of those first 4 questions are yes, then you move on to question 5, which is really asking about current suicidal ideation. So if the patient says yes to question 5, which is really asking specifically about current suicidal ideation, then the patient needs a stat, safety, or full mental health evaluation. If the patient said yes to some of the first 4 questions, which were the screening questions, but they answered no to question number 5, meaning no current suicidal ideation, then they still need a brief safety evaluation. The safety assessment will then determine what the next step is for that patient. Regardless of how the patient responds to the asked questions, everyone should be provided at least one safety resource, such as educating them on 988, the National Suicide Crisis Hotline. The screening instrument I want to spend the most time discussing today is the Columbia-Suicide Severity Rating Scale, or the CSSRS. The basic CSSRS is the one on the right-hand side of this slide. These are yes/no questions that you will be asking the patient directly. You can see that the questions are color-coded, and the color coding is to help you with risk assessment. So yellow represents lower risk, orange, medium or moderate risk, and then red, high risk. And it even says the words high risk on there to catch your attention. So the reason I really like the CSSRS as a screening instrument is because it also provides you with recommendations for what the next step should be depending on the patient's individual risk level. So when it comes to completing this, if the patients answer yes to questions 2 or 3, so have you had any thoughts about killing yourself, or have you thought about how you might do it, then they need a behavioral health evaluation. If they say yes to any of the high risk or red questions, so have you had these thoughts and some intentions of acting on them? Have you worked out a plan? Do you intend to carry out this plan? Have you made any preparations? Those are much more serious things when it comes to suicide risk assessment. And so the high risk categories would be considered an emergency. So at UTMB, we use the Columbia-Suicide Rating Scale that's combined with the SAFE-T protocol. The first part of the instrument is the same CSSRS that we reviewed on the prior slide. Depending on how your institution integrates this into the EMR, you might only have the first 2 questions pop up as screening questions. If both of those are no, then you may be done with your suicide screening at that point. If either of those are yes, then usually it cascades down and asks you to answer additional questions. For the ones that's no on the first 2, that automatically puts them into the lower risk category. So as I mentioned, we use the CSSRS that's combined with the SAFE-T protocol. So what is the SAFE-T protocol? Well, it's really going through and taking a look at some of those risk and protective factors that Benita shared with us earlier. So at UTMB, if any of our patients screen in the moderate or high risk category, meaning they're in those yellow boxes, the orange boxes on the CSSRS, then we go through and complete the SAFE-T assessment as well. And that's going to help us evaluate risk factors, protective factors, and also gather more information about the specific suicidal thoughts that the patient's having. So this is a picture of what the first section of the SAFE-T assessment looks like, and that really focuses on risk factors for suicide. Many of these are the same risk factors that Benita shared earlier in the presentation. The second set of the SAFE-T assessment focuses on identifying individual protective factors. These tend to be more person-specific, so there are a couple of blanks for you to add patient-specific protective factors. For example, your patient may say, I want to live because I want to reach graduation or some certain milestone in their life. Or they may say, I want to live because I want to be around to take care of my pets. Whatever that reason is that they cite, a good place to put it is in these empty boxes on the SAFE-T assessment. The final portion of the SAFE-T assessment is really focusing on specific questions about a person's individual suicidal ideation. So I know this slide is a little bit small, but I wanted you to see what it would look like if you completed this assessment yourself. So higher scores on any of these questions in this particular area indicate higher suicide severity, higher risk of suicide. So the questions that they have you go through and ask the patient, how often are you having these suicidal thoughts? How long do the thoughts last when you do have them? How well can you control your thoughts about suicide? Are there things that have helped stop you from ending your life? And what are some of the reasons that you want to live? The level of risk on the CSSRS really helps the clinicians to decide what the next step should be in their care plan. For the high-risk individuals, they really need an emergent psychiatric evaluation. These are the types of patients that you're going to be sending to the emergency room. You may send them directly to an inpatient facility for admission or evaluation, or you may also be referring them to the local mental health authority to have a crisis evaluation. For the moderate risk individuals, they might just need an urgent evaluation, but they may also be appropriate for outpatient. Sometimes those are the people that really need kind of an in-between service, like an IOP or a PHP, where they can have more regular contact with clinicians, but they may not necessarily need hospital level care. And you really have to take into account your full risk assessment when you're making this decision about what they need. And then for the lower risk individuals in the yellow, those are really appropriate for outpatient referral to a behavioral health specialist. There's also a section at the end of the safety protocol that reminds you what you need to document in your clinical documentation. So you're going to be saying what level of risk is this particular patient. And then these are reminders that help you remember what you want to put in your note. And I want to point out one of those things listed is implementing a safety plan, which is what we're going to discuss over the next few slides. So what is the safety plan? A safety plan is really a list of coping strategies and sources of support that a person can use either before or during a suicidal crisis. The plan is brief, usually written in the patient's own words, and should be easy to read. I will point out that a safety plan is a collaborative effort between a patient and a clinician. It is not something that you should be doing for the patient. It is something that the two of you do jointly together in a visit. Part of every safety plan should also include asking about access to lethal means, such as firearms. So that should be a key part of safety planning. I included a link for a website that helps walk you through developing a safety plan with a patient. And we're also going to break down the individual components of a safety plan in the next few slides. So this is an example template for what a safety plan might look like. Generally, it should be a single page. And we're going to zoom in and take a look at these different areas of the safety plan in the next few slides. So section number 1 of the safety plan is really identifying warning signs that a suicidal crisis might be developing. In other words, helping the patient figure out what are some of their triggers and what are some things that should make them think that they need to get their safety plan out and review it. What are some of the things that tip them off that they're not doing well and their risk level is increasing? Once they've kind of got past that point, section number 2 is really leaning on their internal coping strategies. So what can the patient on their own do to help minimize their suicide risk? This might include ways to distract yourself, like listening to music, exercising, or some other activity that could make the patient think about something other than suicide. If they've tried that and it's still not working, what about some people that they can reach out to that can help distract them, safe places they can go, people they can be around? They don't necessarily have to tell these individuals that they're in crisis, but just identify people that they can reach out to talk to, someone to distract them from the way they feel. If that doesn't work, the next step is really identifying friends and family that they can call for help. At this point, they're letting other people know they're in crisis and they need support. If friends and family are not enough, what about professionals? Who can they call at that point? So section number 5 is really giving them a list of people that they can call or reach out to for in-the-moment support for increasing suicidal thoughts. And step number 6 is really about ensuring the environment is safe. So some of the things that you might be discussing at that point are removing firearms from the home, removing sharps, limiting access to medications, whatever it is. And some of what you decide to remove may be things that come up when you're doing your risk assessment with the patient. So certainly if a patient told me they were having suicidal thoughts and they were thinking about overdosing, one of the main things I'm going to be doing in this part of the safety plan is really making sure that they don't have access to medications, that we don't make it easy for them to potentially hurt themselves. The final item down at the bottom of the safety plan is having the patient identify something worth living for. So if they went through all of those things and they've reached out to people, they've tried to distract themselves, they're reaching out to professionals for help, family for support, and they're still feeling in crisis, the last thing on the list is really reminding them, what is the reason that you want to be here? What is something worth living for? So the other thing I want to point out on this slide is developing a safety plan is not really a one-time thing. This is a living document. It should really be revisited over time, and it really needs to be updated periodically to make sure it's relevant for the patient. For instance, some of these people that the patient relies on for support may change over time. And so making sure that they have an updated safety plan is important. So now that we've made it through that, no talk about suicide would be complete without mentioning physicians. So being physicians, we all belong to a group that is higher risk for suicide. As many as 300 physicians die by suicide every year, and the suicide rate among female physicians is much higher than the general population. So why are we more at risk? These are just a few of the reasons. We have a lot of medical knowledge. We know what lethal means are. We have a lot of stress. We have a lot of work, burnout, substance use rates are higher. We are often taught to put patients first, sometimes neglecting our own mental health. And we're also a little bit hesitant to ask for help when we need it. So what are some of the reasons why physicians avoid getting help? Well, really, sometimes they just can't identify that they're in crisis for themselves. It's also kind of a culture of silence where people are told to continue working and not necessarily take time off for their mental health. So often physicians are so busy providing for patients that they miss their own appointments. They don't get screenings that we normally do for patients to figure out if they have depression. They may feel that the way they feel is normal and not necessarily be concerned about it. And then also, I think physicians in general have concerns that if they do disclose that they have mental health struggles, that it won't remain confidential, and it could affect their role as a clinician. So I just want to remind everyone that your mental health is important, and it's important that you prioritize it. Your life literally depends on it. I think by this point, everyone is aware that we have a new National Suicide and Crisis Lifeline that patients can access. It's available 24/7. You can call or text 988. Many students also have this on the back of their ID badge. So if you're working with a young person and they're wearing their school badge, tell them to look at the back of it. Most often, in almost all the schools I work in, students have that on their badge as a reminder. I also tell patients to take their phone out and we put the phone number in their phone during sessions, just to make sure they have it there. In addition to providing your patients information about 988, you can also provide them information, contact information for the local mental health authority for their area. So each county in Texas is assigned to a local mental health authority, and they all provide 24/7 crisis intervention services. So if you have an individual who's in crisis and needs help accessing a higher level of care, the local mental health authority may be an organization that you can rely on for that assistance. So I want to conclude today by mentioning that if you're interested in gaining additional competency in suicide prevention, you can consider one of the courses going on through CPAN. That's called Safety A. So they're offering free training for primary care doctors on suicide prevention. And there is a link for that webpage on this slide. It provides more information about the various levels of training that you want to participate in. So it ranges from anywhere from a 1-hour on-demand course to a full training course over a several-month period. So depending on your individual interest in this area, you can participate a little bit or you can participate more intensely. All right, I want to open up if there are any questions. And then if anyone has any particular cases or anything that they would like to discuss, this would be a great time to do so.
Please feel free to type any questions you have in the chat box or raise your hand.
Yeah, move back to this screen so now I can see the chat box. So feel free to share anything there.
It's an excellent presentation. And there is one in the chat box.
Looks like that's Miss Laura, who is sharing some more information about how clinicians can sign up for Safety A. So contact your local CPAN team, and she provided the phone number 888-901-2726, and they can provide you more information and help you get signed up if that's something you're interested in pursuing.
Dr. Shotwell, this is Laura Young. I wanted to bring forward something that I hear sometimes when I'm chatting with clinicians at their offices. Sometimes they just feel really uncomfortable with the assessment portion of suicide, the suicide assessment portion, as well as the length of time that they're concerned that this takes. So when you have that conversation with colleagues, with other physicians or clinicians, nurse practitioners, PAs, how do you address that when you coming to the point of this takes so much time? Because of course there are a lot of, when you're seeing patients every 10 or 15 minutes, that this can feel burdensome. And so I just hope, can you share that a little bit?
Yeah, so definitely I feel like I have some luxury being in psychiatry where our visits tend to be a little bit longer than our counterparts in primary care, but those are very valid concerns. It does take a little bit of time to do a suicide risk assessment. It takes even more time to do a suicide risk assessment well. So I definitely hear those concerns. I think it's important to take the time to do it, even though it does seem like a little bit of a burden on the schedule, because as the primary care provider, you may be the only clinician who interacts with these patients that has the ability to do these assessments. And again, the whole purpose of the assessment is really to identify people who are at higher risk and help connect them to higher level care if that's something they need, or to help them develop a safety plan. A safety plan doesn't have to take a lot of time. For the most part, you can do a safety plan in a few minutes. Patients often have phone numbers written down. You can have a list created yourself of resources for your local area that you can give to cover that section on professional stuff. The thing that takes a lot of time is really going through and talking about individual risk factors and individual protective factors. And I think that's sometimes where people feel a little uncomfortable when it comes to suicide assessment is how much weight do I put on any one individual risk or protective factor? How much do I emphasize one over the other? And I think that's where people can spend a lot of time is not knowing when they've collected enough information there or whether it's adequate. Did that answer your question fully, Ms. Laura?
Yes, it did. And there are a couple of chat questions here as well.
All right. Let's see. One was a comment, ADHD children share risk. This is very true. Someone else said, we do not have an IOP in Tyler. We send them to the ER. Many times patients are sent home because they deny being actively suicidal, but there's no services provided or scheduled for the patient. I really don't know how to help these kids needing more intensive services. So yes, even as a psychiatrist, I feel your pain in this area. So even when we identify that someone needs higher level care, sometimes it's a little bit tough to find it. And I will tell you several times I myself have sent patients to the emergency room with a letter outlining the risk, recommending higher level of care, recommending hospitalization. The patient goes to the emergency room, they're screened by the emergency room physician, and they're still sent home, even though they've seen a psychiatrist and I recommended inpatient services. So something that I've relied a little bit on personally in this area is called Charlie Health. It's a virtual intensive outpatient program. It's one of the few kind of higher level care systems across the state that accepts pretty much all Medicaid patients. And so it's a fully virtual IOP where the students get a fair amount of interaction with a therapist on a daily basis. And for those that maybe didn't make it to the hospital setting, but still need someone checking in with them more regularly than you all can do as primary care clinicians, something like a virtual IOP may be that middle ground that you're looking for. And that's called Charlie Health, and you can just put a referral in online. Or as Ms. Laura mentioned, you can always reach out to CPAN, and they can have some of their case managers on their team look for resources as well. Where can we get a copy of the suicide assessment for our practice? I'm using the Kuchner Depression Screen for 12 years and older. If that's possible, and if that is positive, the suicide assessment should follow, correct? I'm not familiar with that particular depression screener, so I'm not sure what the next level of screening would be beyond that.
Dr. Shotwell, we can go ahead and get with Dr. Kim and send her the we want the PHQ-9 and the ASQ. We have those that we provide to our folks here in Northeast Texas.
Gotcha. Yeah, I think that's a little bit tough because there's not a gold standard, so everybody's not doing exactly the same thing. So I would say just pick one and familiarize yourself with it and get comfortable with it, because the more comfortable you are with it, the easier it'll be to do it and the more efficient you'll be in doing these assessments in clinic. I think when it's hard is when you don't use these very often and you try to pull them out in the course of a busy visit when there's a lot going on. That's where a lot of time goes. So staying familiar with this and getting comfortable with the different assessments, I think that's probably the most important thing. I think I answered everything. Were there any other questions?
Dr. Shotwell, if you have folks from the Galveston area that are in your region that are interested in those screening tools, they can contact your CPAN team as well and get those screening tools from you. Would that be correct?
Correct. Or they can also send me an email. I think my information is in the slides. I would be happy to send them as well. But yes, their CPAN team should be able to help as well, or our CPAN team. Let's see. Charlie Health has been helpful for patients willing to do virtual, but I do have patients that refuse virtual or have unreliable internet access. I'll try to remember this resource more often. Yeah, I think especially since COVID, people have gotten more comfortable using virtual resources. Also across the state, a lot of our students are being seen virtually through the TCHAP program. There are some people who unfortunately are not a great fit for virtual, but I think the vast majority of people, I found that to be a reliable resource for referrals. For kids undergoing a new diagnosis of ADHD, if they have high PHQ score, but a majority of the questions scored are for symptoms consistent with ADHD, how do you usually navigate these situations? Well, that's actually a very common thing that comes up clinically. And when they first implemented using the PHQ-9 in our institution, we got a lot of referrals to psychiatry for depression screeners that were high. And many of those were actually patients that had ADHD. There was no depression going on. So I think you have to take a look at the individual questions on the PHQ-9. Some of them are questions that are really more oriented toward ADHD, especially if you kind of take them in isolation. So kids with ADHD often have difficulty concentrating, focusing. They're often fidgety, moving around. They have difficulty sleeping. You know, if they're on medications for ADHD, they may also have weight loss or weight gain. So yeah, that's definitely a clinical question that comes up a lot. If I am not sure if somebody has depression going on in addition to some ADHD symptoms, I usually spend time exploring that a little bit more. And my personal preference is to address depression symptoms first. And then if there are leftover symptoms after depression is well controlled, then usually move on to assessing further for ADHD. And the reason for that is honestly, I feel like the ADHD medications are a little bit more harsh on the mood and on anxiety. And so I think there's some benefit in getting the mood and anxiety symptoms well controlled before you consider introducing those ADHD medications into the picture. You're welcome.
We still have about 4 minutes. Would love to answer any other questions you might have. How often do you get a child psychiatrist right on the phone here and on video to answer questions? And you may have a question that isn't necessarily related to suicide, and would welcome any other questions you might have about child and adolescent mental health. All right, Dr. Shotwell, I think that we have answered all the questions for today. I thank Meredith for stepping in for me. I am coming back from being out of town, and I appreciate her facilitating the front end of this. We will go ahead and get the QR codes put back into the chat so that folks have that information so they can complete their required steps for continuing education, and both for clinicians and for nurses. If you want that information. If you want more information on suicide screening and assessment tools, please contact your local CPAN here, either in Tyler or the CPAN that's located in the Galveston area. Please feel free, as Dr. Shotwell said, please feel free to reach out if you have any additional questions. We look forward to providing you actually with additional education on Safety A starting in 2025. And if you're interested in the links to sign up for Safety A as a clinician, or even as they're allowing nurses in the clinics as well as MAs to attend that Safety A training as well. It's pretty common for that support staff to work in partnership with the clinician in the clinic settings. I know that we have a physician here in Tyler who works very closely with her nurse, and that nurse actually works one-to-one on the safety planning with her patients and is quite skilled at that. So if you want more information on Safety A, please do reach out to CPAN. We'll get you that information. And Dr. Shotwell and Ms. Leilani, thank you so much for your presentation today. We really appreciate it. And we thank you for your attendance. If there's any other questions, please do let us know. Otherwise, we will see you in January of 2025. We have more sessions coming. And I believe the session in 2025 is Horses and Zebras, Understanding the Difference Between PTSD and was it PTSD and something else? I'm sorry, I don't have it in front of me. So thank you very much. Have a great day and have a great holiday season.
Thank you all for your time.